to the
This
demo.
was really good. Finally, the apical window, which is actually my favorite window. And in the starter kit, we already highlighted the potential of this window. Here is a 4-chamber view that helps you to assess, for example, left ventricle function or the mitral valve. Now, I often ask myself, why don't we start a standard exam from the apical window? As a matter of fact, it probably would be equal to the parasternal window. Still, there are situations where one does start with an apical window.
Yes, and we are talking about acute situation, or when you cannot position your patient, I would recommend start with an apical view and then go to parasternal and subcostal view.
Yes, there's only one reason where you cannot use the apical view, and that is if you have a patient who is resuscitated, because there you would be in the field of action where you perform chest compression. But in all other situations, the apical view is a very important view.
We will give you a roadmap which will lead you to get a good 4-chamber view and to avoid pitfalls.
And let's start right away with a very common mistake that is done: incorrect positioning of the patient. Anna is now going to show us how to do it correctly.
I ask my patient first to lie on his left side, but not too much. Remember, we want to have this area really free to move our transducer completely. And then around 4th, 5th intercostal space, I put my transducer. Remember, the marker now is pointing lateral. So playing a little bit, again, I focus only on my machine. I optimize my image, as you learned already. And I get my 4-chamber view. I make sure I can see all the structure in there. And now I will teach you really in a simple way how to move the transducer to optimize your image or to get new views. So to optimize your image, I would recommend you to move the transducer in 3 ways. So what you can do is moving the transducer from lateral to medial and back. You can go more cranial and caudal. You can do slight rotations, and this you will understand it's mainly for the right ventricle. So when we start with the first movement, actually when you put a probe on your patient, I recommend start from lateral and get medially to have your image, to have the 4-chamber view. This is actually a quicker way to get it. And make sure that the septum gets parallel to your ultrasound beam. So actually, when I go lateral, my image is like this. I really can see the right ventricle. When I get lateral, the septum goes parallel to the beam. And then again medial, I focus on the left ventricle. So with this movement, I can both optimize my image, or I can use these views for my advantage to focus on the right ventricle. I will put the transducer more lateral, or to focus on the left ventricle, now I would put the transducer more medial. So this was the first movement you can do with your transducer, and then a really important one, your transducer you could move more cranial and caudal. We already talked a little bit about foreshortening. This happens when your transducer is too cranial, so your ventricle looks more round. And this is not a good ventricle. It's good to estimate left ventricular function, but still, when you want to measure, it's better to have better image moving the transducer caudally. And then I'll teach you the last movement you can do. It's mainly for the right ventricle, as I told you. Sometimes the ventricle is completely normal in your patient, but you image it as extremely big. And what does it depend on? It depends on the probe. So actually, with small rotation, you can see what happens to the right ventricle. It gets smaller, and gets normal size, gets bigger. So actually, the right image is the one where you can see the two leaflets of the tricuspid valve really opening and closing.
So foreshortening is an important thing to consider if you want to get a good four-chamber view, because as we already mentioned, you will not see the entire apex, but it is only important if you want to quantify the size and the volume of the ventricle and if you want to look at the supraapical position.
Yes, because when you want to assess the valves, actually it doesn't matter whether you have foreshortening or not, because the valves do not really care about foreshortening.
Yes, that's completely true. As long as you see the valves, it's good. So remember, foreshortening for the ventricle, but for the valves, who cares?
But we are not done yet with the four-chamber view. Thomas is going to show us some more structures.
So you're all familiar now with the four-chamber view, but I want to show you some additional things that you might have not known. There is more anatomy to show. First of all, we have the anterior leaflet here and the posterior leaflet here of the mitral valve. And then right here in this groove between the left ventricle and the left atrium, we have the coronary sinus. And then close to that, we have a vessel that enters the left atrium, which is the left upper pulmonary vein. Usually not seen here on the simulator, you would also have the left atrial appendage very close here. Then we have a second pulmonic vein that enters the left atrium here from the top right. This is the right upper pulmonic vein. And then finally, outside the heart, very close to the left atrium, we would see the aorta, which is hit orthogonally. This is the descending aorta.
So the simulator is very cool.
Yes, I like the simulator because it gives you a very good appreciation for the structures and you know what is bordering to which structure. And if you ever have the chance to work on the simulator, do it. I learned a lot from it. There's only one thing that the simulator cannot do, and that is help you understand the positioning and the habitus of the patient. And that truly makes a difference as well. So I want to show you on this model. Now, if you have a patient who has a normal habitus, the axis of the heart from the base to the apex will be something like this. Now, if the patient is very obese, the diaphragma will be more cranial. This means that the axis will change. The apex will turn, first of all, more cranial and also more lateral. Vice versa, if you have a patient who is very slim, then the heart will have an axis which is more like this, which has the problem that it is now kind of hidden behind the sternum here. That makes it difficult as well. So the ideal patient is the one that has an axis somewhere in the middle here and not too far lateral and not too far medial, because remember, we have the lungs in the lateral region.
Yes, and there's another issue. It's women and breast. And actually, when you want to image a woman, you have to stay just underneath the breast, because usually it's difficult to image through the breast.
Right, remember, the breast is not really at the portion of the fifth intercostal space where you image a man. So it's a little bit cranial, so it does not really present an obstacle, as long as you image from underneath the breast.
And the last thing we want to mention is the role of the lungs and the ribs.
Yes, because if you take a close look, the problem we have is that we can neither image through the lung nor through bone, and the imaging windows are sometimes quite small. So to get the heart in your field of view, what you can do is you can use respiration for your advantage. For example, you can let the patients exhale, thereby the lung will move more lateral and open up a window. But sometimes inspiration is just as good, because by inspiration you can move the heart position up and down, and thereby it can come into your field of view. And then finally, we always learn that we should image in the intercostal space. My advice to you is that you sometimes use the rib to your advantage, and you can place the transducer right here on the corner of the rib, and thereby you can get an angle into the intercostal space which allows you to peek behind, for example here, the rib which is further below. So these are some of the tricks that I think that can help you in your daily practice and to help improve your image quality.
But before we go on, Thomas, what do you think is the biggest mistake people do when they image from apical position?
Well, I've mentioned that already in the first demo, but I can only emphasize is that the people usually image not enough lateral. And I will show you now on the simulator how to avoid that and what happens if you do move the transducer off of the very far lateral position.
Let me help you to optimize the image for a very good 4-chamber view. Here we have, of course, all 4 chambers in the field of view, but the septum is not parallel to the ultrasound beam. To optimize the septal position, we need to move the transducer more laterally, kind of encircling the apex until you finally have the septum parallel. This would be the optimal position if you want to measure, for example. But for certain pathologies, as already mentioned, it might be better if you really put the transducer so that you do have a slanted septum, in this case to optimize the lateral wall, and if you want to go even further lateral, to optimize for the right ventricle. So these views are atypical views, but they can be helpful in certain situations. But remember, it's this encircling motion of the apex that really helps you.
And this is what you have to do. You have to encircle the ventricle from medial to lateral. And again, for a quick review, this is how the septum changes the position in regards to your position when you are medial and lateral. And here's a live example, again, medial, central, and lateral position.
Yes, and while the one in the middle is the one that is always taught as the standard view in textbooks, don't forget that the image on the left is so ideal to look at the lateral wall, and the image way on the right is, for me, the view that I use if I look at the right ventricle.
And you know, there's something else which can go wrong, and Thomas will show you.
What's wrong with this 4-chamber view? Well, the rotation is not optimal. To optimize your rotation, you have to see that the right ventricle is as large as possible. So see what happens to the right ventricle when I now rotate clockwise. See, all of a sudden, the right ventricle gets a lot larger.
And this is so fundamental. Again, look here. You may think the right ventricle is a good one, but the rotation here is too far counterclockwise. You can adjust it by doing a rotation clockwise, and look how the ventricle gets bigger and bigger.
Yes, that's correct. And if you rotate even further, what will eventually happen is you will get a view that looks like the following view. See what happens now? All of a sudden we have the aorta in our field of view. So you see that you can get a view which looks pretty much like a 5-chamber view, a view that you'll learn in the next part of our section here. But important to understand, the rotation makes a difference if you want to quantify the size and also in which structures you see.
And the last important thing just to remember is foreshortening. So here, for instance, we are too cranial with a probe, and the ventricle is more rounded and shortened. The optimal view is the one below.
Again, but only for the ventricle, not for the valves.
Here's another example of very reduced left ventricular function in the context of a dilated ventricle.
Just note how round this ventricle is here. This will be something that we'll talk about in the chapter on left ventricular dysfunction. And here we have an interesting case. Now, I guess you will all agree that left ventricular function is pretty normal, but there are some interesting things to see here. Look at these regions of calcification. Now, this is interesting because this was a patient who was on high doses of calcium because she had juvenile arthritis and osteoporosis, and this somehow led to calcifications of the entire heart, actually, including the pericardium. So all of these things we can pick up with echocardiography and with the 4-chamber view.
But enough with a 4-chamber view. There are other views you can generate just by tilting and rotating your transducer. When you tilt the transducer, you can get a 5-chamber view or a coronary sinus view. When you rotate it, you can generate the 2- and 3-chamber views. Let's start with the tilting motion. And when you tilt the transducer more cranially, you generate a 5-chamber views. When you go posteriorly, so you tilt it caudally, you generate a coronary sinus view. And this is actually what happens. We are 4-chamber view, we tilt the transducer more cranially, and the aorta opens with the ascending aorta. When we go back to 4-chamber view and we tilt more caudally, we generate the coronary sinus view. And here you can really see the coronary sinus.
Let's see some examples. Here on the left, we have a normal 5-chamber view. We see the aorta right here in our field of view. And here on the right is definitely a pathology. On the aortic valve, you see that it's calcified, I guess. Many of you probably recognize the pathology already. This patient has some degree of aortic stenosis. But there's another pathology here. Look at the mitral valve. Here is a calcification here, and the valve looks thickened as well. So we can use the 5-chamber view to look at the aorta and the mitral valve.
Yes, and here is another example. Again, a normal heart on the left side, and here on the right side, 5-chamber view with something moving on the aortic valve. This patient ended up to have infection, and this is a clear example of endocarditis. And just to sum up, what is the 5-chamber view good for? Well, to assess global function, regional function, the aortic valve, and the mitral valve, especially mitral regurgitation.
Yeah, if you want to look at the anterolateral portion of the mitral valve, this is a good view to do that.
And now let's move on to the 2 and 3 chamber views. Probably it's better to understand this using the simulator.
I want you now to watch what happens on the anatomic image here on the left when I rotate to the 2-chamber view and then later to the apical 3-chamber view, or the apical long axis view as it is also called. Now here we have the 4-chamber view, and I am now rotating slowly counterclockwise. You see that the right ventricle is slowly starting to vanish, and we are now looking at the anterior part of the body here and the posterior part here. You see that the diaphragm is coming into the field of view, and so now we have the 2-chamber view with only the left ventricle and the left atrial visible. We have the mitral valve, which cannot be distinguished anterior-posterior leaflet, and we see here actually the descending aorta in kind of a long axis view if you play around a little bit. So this is the 2-chamber view, and now I will continue my rotation and rotate until we get the ascending aorta into our field of view. Again, look at the image here and watch for this region. All of a sudden here the ascending aorta pops out. This is the 3rd chamber. We again see the mitral valve, and we see a little bit different portions of the myocardium here, posterolateral and anterior. We still see a little bit of the right ventricle. We're cutting through the right ventricle as well. Now, what is the advantage of using all of these views? I will show you. Here's the 4-chamber view, and if you rotate a little bit, you will all of a sudden appreciate that you have probably more of the apex in your field of view in the 2-chamber view, and thereby you can see a pathology that we played into the simulator, namely a thrombus. So here we see this thrombus very nicely, and the advantage of the 2-chamber view is that you can see more of the apex usually. So use that in conjunction with atypical views, and you will even catch such pathologies as this thrombus.
And let me demonstrate this once more. When you see in this image, we start with a 4-chamber view, and you see the right ventricle, it's getting smaller and smaller, disappearing. We are rotating counterclockwise till we get to a 2-chamber view. And here, by keeping on rotating, you see the aorta is coming into the view, and this is how we get to the 3-chamber view, keeping on with the rotation counterclockwise.
And remember, if you do the rotation, try to always have the left ventricle right in the middle of the sector, so you're rotating around the middle of the sector.
And again, for you to remember, here we have the 5-chamber view, the 3-chamber view, also called the long axis, and the 2-chamber view.
In the 5-chamber view, we have the right ventricle and left ventricle. And Anna, do you actually know why it's called the 5-chamber view? Where the hell is the 5th chamber here?
Well, it's actually the aorta. So
yeah, I don't know who came up with this idea of calling the aorta a chamber, but that's just the name it has, and that's the thing you have to remember. The other important message here is that we see different portions of the ventricle. This will be very important later when it comes to looking at different wall motion abnormalities in different parts of the ventricle.
And here I think this sequence of complete rotation from 4-chamber view through the 2-chamber view till the 3-chamber really allows you to understand.
Yeah, I think the nice thing here is that you can understand how you get from one to the other. For example, right here, that the right ventricle is starting to vanish, and as soon as it's gone, that's when you have the 2-chamber view. And then when on the other side, all of a sudden, the aortic valve starts to open, that's when you get into the 3-chamber view. Now, I know there's different angles which you read in textbooks, but nobody is going to look at angles when they rotate. You can look at the image. And these are the key structures you have to keep in mind when you do the rotation.
And here are some examples of pathologies in 2-chamber view. So on the left, we have a normal heart. On the right, you can appreciate the left ventricular function is reduced. So 2-chamber view also for global function. And here, this small round structure, as you can see, is the coronary sinus.
Yes, it's definitely coronary sinus because it's located right on the junction between the left ventricle and the left atrium. So this here is the coronary sinus here. One other thing that I want to just show you, when you look at this normal image here, don't think that this is a thrombus or some pathology. It's just an artifact that you frequently see. It's a so-called near-field artifact.
And moving on, we have another example here. Do you notice something abnormal?
Yeah, one thing I notice is that the patient doesn't seem to have a normal rhythm. You see that he has probably atrial fibrillation with a very short contraction phase here, a very short R interval, where it's very difficult to assess left ventricle function, but I think this patient has reduced function.
And moving to the next case, we have again left ventricular hypertrophy, so we can also see it in the 2-chamber view.
Yeah, massive LVH here at the apex. Remember, we can see the apex very nicely in the 2-chamber view. We showed you in the demonstration that you can actually see a thrombus there, for example. So that's one of the things that the 2-chamber view is actually good for.
And just to sum up, what is the 2-chamber view good for? Well, again, for global function, to assess the presence of a thrombus in the apex, as we showed you in the demonstration, to assess regional function, and again, mitral valve with respect to mitral regurgitation especially.
And here are some pathologies seen in an apical long axis view. On the left-hand side, again, a normal left ventricle, and on the right, what can you see?
Well, an extremely dilated left ventricle with poor left ventricular function.
Right. The patient had an anterior infarct. You can see the scar right here, and function is very poor.
And in the next example, we have, again, normal ventricle on the left, and on the right, when you focus on the aortic valve, you see the structure, you see a nice structure. Well, this patient underwent a TAVI procedure, so he received a prosthesis.
Right, this is an aortic valve prosthesis. Since we can see the aortic valve in this view, that's also the view we could see, for example, a prosthesis. And then finally in this view, we have a very echogenic structure right here. A very common finding actually, especially in patients who are under dialysis, as this patient was. This is what we call mitral annular calcification. So to sum up, what are the things that the 3-chamber view is good for?
Well, to assess again global function and regional function, to assess the LVOT, for instance, any obstruction there, and again, mitral valve in respect to mitral regurgitation.
So many tips and tricks and so many views and pathologies. So I think from all this, I'm sure you will be able to answer these few questions.
So, for instance, what would you do to optimize this view? Well, you see the ventricle, the right ventricle is really small. Well, you need to rotate your probe clockwise, and you see how it changes. So the ventricle reaches its real size.
Yeah, look, compare this to this.
And another example, what would you do here? Well, you only need to go more caudal because this is a typical example of foreshortening.
Yes, look how short the ventricle is here compared to here. You're missing out on a lot of part of the left ventricle here.
And last example for you. What would you do here? This is easy. Well, a small maneuver, I would go more medial with my transducer to have the septum in the right position.
Look how slanted the septum is here. If you move more medial, you will have an orientation which is more towards the direction of the ultrasound beam. So this basically concludes this chapter on the apical window. We have one last window for you, which is the subcostal window. Stay tuned.